if we have to arrange the symptoms in decreasing order, how will we arrange them? The first of all, it is pain. So as I told you, 70% will have secondary dysmenorrhea. Then comes infertility, then comes chocolate cyst, and then comes the menstrual symptoms. Okay, so this is the menstrual symptoms. MC means menstrual cycle. So pain followed by infertility, followed by chocolate cyst, and then followed by the menstrual symptoms. But the clinical triad is dysmenorrhea, menorrhagia, and dyspareunia. Remember that. Okay. So what are the causes of infertility in pelvic endometriosis? Let us first talk about the ovary. What are the problems in ovary that lead to infertility? First of all, if there is a chocolate cyst, now it is very obvious. If there is a chocolate cyst, it is going to damage the follicles, right? It is definitely going to damage the follicles. So follicular damage is there, and that can lead to reduction in the AMH. AMH, that is an anti-Mullerian hormone, which is giving us an idea about the number of follicles in the ovary and kind of indirectly points towards the ovarian function. So chocolate cyst itself is destroying the ovary. It is destroying the follicles. Then there may be defective folliculogenesis. Defective folliculogenesis, why does it happen? It happens because of inflammatory reaction. Inflammatory cytokines can disturb this and lead to defective folliculogenesis. Then there may be anovulation. There may be luteal phase defect because of hyperestrogenic condition. Similarly, LUFS. LUFS is again luteinized unruptured follicle. Luteinized unruptured follicle means what? It is due to increased estrogen, which is now inhibiting the FSH. So FSH is getting inhibited, because of which there is luteinized unruptured follicle syndrome. Means it is not ruptured, it just gets luteinized because FSH is basically decreasing because of the high estrogen. What can be the other causes of ovary pertaining to ovary? Hyperprolactinemia. Now it is not directly related to ovary because prolactin is coming from the pituitary, but because it is affecting the menstrual cycle, the entire HPO axis, so it is kind of a part of ovarian dysfunction only. So hyperprolactinemia is commonly seen in endometriosis. Apart from this, there may be oocyte maturation defect and there may be luteolysis. Means the corpus luteum gets luteinized very soon, and that is because of increased PGF2 alpha. That is, the prostaglandin F2 alpha is increasing, and that is causing increased luteolysis of corpus luteum before it should actually disintegrate on its own. Now we know in a normal menstrual cycle, corpus luteum is formed on the 14th day after ovulation, and it stays till 24th, 25th day. It maintains the production of progesterone, gives the secretory changes to the endometrium so that the pregnancy can come, and it prepares the uterus for pregnancy. And then it starts disintegrating after day 25 if the pregnancy does not happen. But in this case, there may be early luteolysis. So LPD, LUFS and luteolysis, these are all part and parcel of the same game. That is, PGF2 alpha is increasing because E2 is increasing and FSH is decreasing. What are the tubal causes of infertility in endometriosis? They are very, very obvious. Now obviously, if there is adhesion outside, the tubal motility will be altered. Even though the tube is not getting obstructed from inside, we have studied this in the other chapter in the endometrial causes and pathogenesis, and the tube does not get blocked because endometrium does not go inside the tube, but it is causing adhesions. It is implanting on the serosa of the tube. So it can lead to altered tubal motility due to adhesions, right? Then it can cause, because of pelvic adhesions, there may be tubal obstruction. The fimbria might get kind of coalesced together and they might get matted together. So there is distal tubal obstruction. Distortion of the normal tube is very common. The ovary and the tube, they are in relationship together. Okay, so that is the fimbria, and there is an ovarian fimbria which is attached to the ovary like this. So they have a relation. That is why when the ovum is extruded from the ovary, it is caught by the tube, but this relationship is altered in case of endometriosis because of adhesions. Plus there may be impaired fimbrial pickup, that is again because of the altered relationship.